Our next speaker is Erik Fromme, previously from Oregon, now Director of Serious Illness Care Program at Ariadne Labs at the Dana-Farber in Massachusetts.
Thank you, Neil. Can people hear me if I speak at this level? Okay. So let me see. So yes, as Neil said, well, 16 years ago, I went from Boston to Portland, where I've been working as a palliative care physician at one of the organizations, health systems that allowed its physicians to participate in physician aid in dying. For that entire time, actually, I've been a non-prescriber, and I think that's why I was invited to participate. Actually, my practice has been to never talk about physician aid in dying publicly. And partly that was in order for practical reasons. As the head of a palliative care program, I wanted to maintain a separation between the two and make sort of a bright line there. But I realize now that I picked a hell of a time to change that policy. But all right, but now I'm in Boston again, so I figure I'm not in the same role. So, and what I do have now, though, is as a non-prescriber, 15 years of experience in working with patients who are both very interested in physician aid in dying and those who have absolutely no interest in it as well. And the goal, just to be obvious, from my standpoint, is to maintain the ability to care for patients, whether they're for or against physician aid in dying. My other main points I'll just make here at the outset, because I probably won't get to the end of my slides, is that I think, in my opinion, clinicians should never be in the position of suggesting physician aid in dying as an option. As has been mentioned multiple times, there are many health systems that sort of automatically opt out, and I can describe what it's like if you're in a health system that doesn't do that. And then the necessity of respecting individual health professionals' rights to not be involved means that accessibility becomes highly dependent on health professionals' personal stance, not just for individual providers, but actually at a system level as well. And I'll illustrate what I mean by that point. So some challenges for palliative care. As I said, our goal is to be able to care for all patients, regardless of how they feel about physician aid in dying. And I decided early on that I was not going to write prescriptions. But then, so I was faced with a number of, I had to take care of the patients. And the patients are really interested in this. And I thought, well, shouldn't palliative care be a resource for cases where prognosis or decision-making capacity are not clear-cut? I think Tony mentioned in the first presentation, a lot of doctors, they do this once in their career. How well are you going to do something if you only ever do it once? What if the service that has the most experience in caring for terminally ill patients refuses to involve themselves? I didn't feel that that was a viable stance. How do you ensure that your service, though, so if you are involved, how do you ensure that your service can be seen as a resource to patients, and more importantly, referring clinicians who are adamantly opposed to the practice? And then this question I have for myself, I tried to maintain a bright line for the whole time that I was there, but I'm not sure how important it is to keep palliative care and physician aid in dying separate in the minds of clinicians and patients and families. So I'll just say in urban areas, access is limited. In Portland, the three faith-based health systems and the VA, which comprised probably the majority of healthcare in the city, and many smaller physician groups adopted policies that forbade physicians to prescribe. Intentionally or not, this also inhibited an open discussion at those places. It forced patients into the position of either abandoning their request or seeking care from one of the two health systems that hadn't forbidden prescription. Interestingly, one of the health systems actually has changed its approach over time. In 1997, their policy was neither to encourage or discourage, but they forbade their physicians from prescribing for serving as consultants or referring patients anywhere else. In 2004, they updated their policy to allow their physicians to refer patients to other resources and to act as consultants. And then in 2018, they decided to allow their physicians to prescribe end-of-life medications. And the rationale, it was driven by their ethics committee. And the justification was that they were getting a lot of feedback that providers felt forced to abandon patients at their time of greatest need, often after a long and difficult medical journey. So in rural, the cases have been well made. Access is really unclear. The rate of requests is low. There's no access often to specialty palliative care. Actually, early on, this is changing, but many hospice organizations adopted policies to not participate. And then physicians in rural communities would tell us, confidentially that they didn't want to get involved because of concerns that they would alienate some of the people in their communities. Everybody talks. So I wanted to address a point that Dan made, which I agree with. I don't think you can say that palliative care somehow got better in Oregon because of the Death with Dignity legislation. What you can say is that ethics leaders in Oregon, particularly in Portland, used the physician aid in dying statute to leverage multiple institutions to make tangible investments in palliative care. And a lot of the palliative care programs in Oregon date back to the time of the legislation. And the argument that was used was, what do you want to be known for? In terms of handling requests, there's this sort of tension between non-encouragement and non-abandonment. I'll also say you have to have a different approach to handling patients who just want a prescription versus patients who are worried and think they might need a prescription because they're worried about things getting out of control at the end. And those may sound overlapping, but in my experience, they're two very distinct groups of people. As I said, health professionals should never suggest physician aid in dying as an alternative. One of the state's most vocal opponents, he was in the gentleman's slide earlier, claimed that his activism was triggered by his wife's physician suggesting that she had the option of doing physician aid in dying. And he also referenced some of the health plan denials for medical treatment that then said, but we will cover palliative comfort care, or should you choose doctor-assisted suicide. If you are trying to organizationally deal with requests, what you discover is that there's many physicians who are unwilling to prescribe or be involved at all as consultants, that there's a lot of physicians who are undecided, sort of waiting on their first request, and then the physicians who made up their minds sort of fall into willingness or not in four areas. Basically, are they willing to prescribe or not for their own patients versus any patient? Are they willing to consult but not prescribe for their own patients versus any patient? So at our organization, this process was initially managed by the Patient Advocate Office, has been described. The navigators, they handle calls from patients outside the system, help patients navigate our system, including helping them find a prescribing physician, helped ensure reporting requirements were met. It shouldn't work this way, but it turned out this process was highly dependent on the patient advocate's personal stance. And it worked because she felt strongly that this was their job to do that. However, her successor actually felt like that was not in the scope was different. And so all of a sudden for the entire organization, there was this sort of lack of clarity. But her effort was to try to push the responsibility back onto clinics. Some of the clinics would respond effectively to this request. Some got so few requests that they just kind of left it up in the air. So a large clinic solution was clinicians responded to a semi-anonymous survey to indicate their willingness to consult and prescribe for their own or others' patients. Social workers and clinic leadership had access to the results. Requests were triaged to social workers who knew they knew the individual physician attitudes and could help patients navigate whether their physician was someone who's willing to engage or not. And they were instructed to inform patients that it was the patient's responsibility to drive the process, that we were not going to nag them to do it. This should be a patient-driven process, but all the points about how complicated it is to navigate the health system to access physician aid in dying, just to restate what's already been said many times, does create a major hurdle and an access disparity. And then my experience with handling refusals is that prognostic uncertainty puts clinicians in a really vulnerable position. And this question that Dr. Lin articulated of how certain do you have to be in order to do this, I think most of us interpret that as pretty darn certain for an event of this magnitude. And that's very difficult to be. I didn't have an experience, I never had a frivolous request. Everybody who came, who was interested in this, who was pursuing it, came with an extremely well thought out, well developed, articulate argument. I shouldn't say articulate. Some people are articulate, some people are not. But if you give them time, they're articulate on this subject. I found that patients uniformly requested clinicians' personal moral boundaries about participations. As was mentioned, if the physician knows how they feel about it, it's really important for them to say that up front so that the patients don't waste their time. Patients who were not thought to be terminally ill were anxious but generally willing to wait and see. Patients who didn't qualify because they do not or will not have decision-making capacity are angry. I think my experience of the rarity of psychiatric referrals, it's not that oncologists are determining that patients do not have decision-making capacity and don't bother to refer them to psychiatrists. I think any physician who's contemplating refusing a request based on a psychiatric diagnosis is going to make the psychiatrists make that call. I think that's the answer. That's my answer to the question that Dr. Pope asked earlier. But I also think the low rate of psychiatric referral reflects the fact that these requests are not frivolous. They're extremely well thought through. And I might add, it's apparent to me that some patients are coached not to endorse depressive or anxiety symptoms. They're sort of coached how to say the right thing and not say the wrong thing in order to get a prescription. So let's see. I think that's the end of my time, so I'm going to stop right there, except to say, I wanted to say that the difference for me between this practice and suicide is, the way that I put it together, is that physician aid in dying allows patients to do this within community. They don't have to leave their community in order to do this practice, and that was a really powerful theme that occurred over and over. Thank you.